So, good morning, classmates, and good morning, ma'am. For today, I will be reporting about the questions from last week. So, first is how does hepcidine affect iron? Please provide diagram. So, here is a diagram I found online, and this shows that the function or the role of hepcidine in the iron regulation. So, as we all know, hepcidine is the regular principal regulator of iron absorption and its distribution. It influences iron absorption through the attachment of hepcidine to the ferroportins. Shown here is the ferroportin. It is the green cylindrically shaped icon or something. So ferroportins are transmembrane proteins that are usually found in macrophages, enterocytes, and it is a protein that transports iron from inside the cells outside into the blood plasma. As shown in the diagram, low hepcidine allows iron to pass from inside the cell outside, leaving a low number of iron in the iron storage protein, the ferritin. Meanwhile, if there is a high expression of hepcidine, the hepcidine attach themselves to the ferroportins, therefore not allowing all the iron absorbed by the cell to go out into the blood plasma, leading to a low plasma iron levels. So, in summary, if there is high levels of hepcidine, there is decreased surface ferroportins, there is leading to decreased absorption of iron and uh, decreased recycling of iron from macrophages, leading to decreased plasma iron. So next is why do RBCs in iron deficiency anemia take an extracellular division producing microcytic cells? So iron deficiency is characterized by iron insufficiency. If the supply is low to produce the normal quantities of hemoglobin, the bone marrow is forced to produce cells that are smaller than normal and poorly filled with hemoglobin. So I've also found another point of view or like explanation. So it states that abnormalities in heme or globin synthesis result in deficient hemoglobin synthesis and a delay in the signal for cell division to cease. When this happens, one or more extra cell divisions occur during erythroid cell development, resulting in the formation of microcytic erythrocytes. So they basically have the almost the same explanation. So that's the reason why there is an extra cell division that results in a smaller size of the RBCs in the presence of iron deficiency anemia. So this leads us to the next question. So how does anisocytosis in IDA present in a blood smear? So anisocytosis is the variation of size. In iron deficiency anemia, it presents with anisocytosis, specifically microcytic anisocytosis, meaning that the RBCs are smaller than a normal RBC. So in this picture, on the right are the normal red blood cells we can see in a peripheral blood smear, and on the right is the anisocytotic and microcytic RBCs. We could see that due to the severely hypochromicity of the RBCs, the body's compensation is to produce a smaller RBC by having an extra cell division. And we could see on the slide that some of the RBCs are already smaller than a normal RBC. So, yes. Next question is, what are the different red cell indices and parameters and the reference ranges? So we have the mean cell volume, which is the average volume of an RBC. It is expressed as femtoliters or 10 raised to negative 15 liter. Then the normal range is 80 to 96. So it is, if calculated, it would be the result of hematocrit multiplied by 10 divided by the RBC count. Then we have the mean cell hemoglobin, which is the average weight of hemoglobin in the RBC, and it is usually expressed as picograms, and the normal range is 27 to 33. If calculated, it is the result of hemoglobin multiplied by 10 divided by the RBC count. Next is the mean cell hemoglobin concentration, or the MCHC, which is the average concentration of hemoglobin in the RBC volume. So it is expressed as grams per deciliter, and the normal range is 33.4 to 35.5. It is calculated as hemoglobin multiplied by 100 over the hematocrit count. Last is the red cell distribution width, which is a coefficient of variation in size distribution of RBC. So it is expressed as percentage, and the reference range is 12.2 to 16.1 in females and 11.8 to 14.5 for males. So it is calculated as the standard deviation of the MCV multiplied by 100 over the MCV. So these are the most extensive normal values I found online regarding the usual CBC count that are related to red cells, and that includes differentiating values between or across all ages. So yeah, they are so specific. So these are the normal reference ranges that is depending on the age and gender. We could see that values are generally smaller or lower in females, highlighted in the especially in the adolescent stages due to the differences in body mechanisms such as menstruation. So, how this I got this reference range from Mayo Clinic, but I haven't read of a literature that explains specifically why there is so much fluctuation on the normal values depending on the specific age range, um, especially on the earlier stages of from birth uh, to at least 5 years old. There are so many fluctuating normal values. So I haven't read of a specific explanation on why they have this kind of fluctuation. So, but if we are to infer regarding our past discussions, I believe this is due to how iron is needed and utilized by the body, especially during the episodes of growth from birth to a toddler, then from a toddler to a child, then a child to a prepubescent teen, and then to a teenager, and then finally to adulthood. So, yes. Next, what are the different proteins involved in iron studies and their function? So, first is the ferritin. which is the intracellular storage of iron. Next is the serum iron. This is the serum iron measured is the ferric iron, a ferric iron that is bound to the serum transferrin. Transferrin is the iron transport protein in the plasma. Then we have the total iron binding capacity, which is an alternative test for measuring transferrin as it reflects the availability of iron binding sites on transferrin. And we have the UIBC, which is a measure of transferrin in the serum that does not have bound ferric iron. So for calculations, TIBC is the result of addition of the UIBC and the serum iron. While the transferrin saturation is serum iron divided by the TIBC multiplied by 100, which is expressed, this is expressed as a percentage. So for the reference range, for the ferritin, we have 15 to 200 microgram per liter. Then the serum iron, 10.74 to 30.43 micromoles per liter. TIBC, 42.96 to 80 to 55 micromoles per liter. Then for the UIBC, we have 12 to 43 for males and 13 to 56 for females. For transferrin saturation, we have 25 to 45%. Explain the oxygen hemoglobin dissociation curve. The oxygen hemoglobin dissociation curve correlates the oxygen saturation of hemoglobin across a range of oxygen pressures. So, you could see here the standard dissociation curve, and we could see that there's this line here that that says P50. So with P50 is the pressure at which hemoglobin is 50% saturated. So saturated here means that the hemoglobin have unattached oxygen. So if we could recall, hemoglobin is made up of uh, four subunits. So it could attach or it could carry four oxygen. So if the saturation is 50%, it means that the hemoglobin carries only half of the four, so it carries two oxygen molecules. So if its saturation is at 100%, there is full capacity of the hemoglobin carrying all four molecules of oxygen. And if it only have 75% saturation, then only 3 out of 4 oxygen are carried by the hemoglobin. So um, in the arterial blood, uh, there is a 100% saturation of blood, and in the venous blood we only have 75% saturation. So um, so regarding the shifts, the left shift and the right shift, I will discuss the reasons later, but I will explain the flow on why on first on why a a an oxygen hemoglobin dissociation curve would shift to the right. So first is there is a carbon dioxide production during aerobic metabolism. So this CO2 would dissolve into blood plasma, increasing the partial pressure of CO2. Then the increase in CO2 there will be an increased amount of CO2 that would get inside the RBC. And while inside the RBC, the carbon dioxide and H2O would form carbonic acid, and it would split into bicarbonate and hydrogen ions. So if there is an increase in hydrogen ion, there will be lowering of pH. So please do note that an increase in CO2 would mean, or would also mean, or would also result in a increase in hydrogen ions, so therefore lowering the pH. So both the CO2 and the hydrogen can bind to hemoglobin. However, it does not compete with the oxygen binding sites of the hemoglobin, but it still stabilizes the T state of hemoglobin, or the tense state, therefore decreasing the hemoglobin affinity to oxygen and forcing the unloading of the oxygen to the tissues that needs it. So this is an explanation for the shift to the right of the oxygen hemoglobin dissociation curve. So please take note of those factors I said. So there is an increased CO2, then lowered pH or decrease in the pH, resulting in decreased hemoglobin affinity. So another reason why there would be a shift in the right of the curve is increase in the 2,3-DPG. So it is 2,3-DPG is a metabolic byproduct of glycolysis. So 2,3-DPG is diphosphoglyceric acid, and it is increased in presence of hypoxia. So 2,3-DPG is negatively charged and is therefore attracted to the positively charged center of the hemoglobin. So again, it does not compete with the oxygen binding site. However, it stabilizes the tense state of the hemoglobin. Therefore, same as with the increased CO2, it results in decreased affinity of the hemoglobin to oxygen, and it forces unloading of oxygen on the tissues. So another factor is the increased temperature, which affects the bond of iron and the oxygen. Again, it favors, or it stabilizes the T state, and it results in the unloading of oxygen to the tissues. Another factor is the type of hemoglobin. So the type of hemoglobin present in the blood can also affect the shifting of the oxygen hemoglobin dissociation curve. So for our example, we have the hemoglobin A and the fetal hemoglobin. So comparing the two, the hemoglobin A has lower affinity for oxygen compared to the fetal hemoglobin. This is because babies during gestation, they need to compete with their mother for oxygen. Therefore, the need for the fetal hemoglobin. So it's another factor on why there would be a shift to the right on the oxygen hemoglobin dissociation curve. So ayan, these are the reasons of why there is a shift to the right or the shift to the left. So as I've said earlier, the shift to the right is caused by low pH or increase in the hydrogen ion, increase in CO2, high temperature, and high levels of 2,3 BPG. So the right shifted curve is associated with reduced oxygen affinity and increased offloading of oxygen to the tissues. While the left shifted curve is the opposite, so it increases oxygen affinity to the hemoglobin, which is the relaxed state or the R state, and as a consequence, there is a reduced oxygen offloading to the tissues because the oxygen and the hemoglobin have high affinity. So it's difficult to separate the two. So this is caused by high pH, then low temperature, and as I've mentioned earlier, the fetal hemoglobin, which is a hemoglobin that naturally have high affinity to oxygen. So next question, is the HLA, DQ2, and DQ8 a mutant gene? So, according to what read, HLA, DQ2, and DQ8 genes are not mutant genes. They are inherited genes, and one may have DQ2 or DQ8 in one of the copies or in both. So people who have only one copy of DQ2 or DQ8 have risk of having the celiac disease, whereas this risk is increased if the person have two copies. So almost all people with celiac disease have at least one of the DQ or the DQ8 HLA gene. Uh, Next is what is the role of zinc in iron metabolism? So as I've mentioned last week, there is a test, a special test for characterizing iron deficiency anemia, which is the FEP or ZPP. So FEP is the free erythrocyte protoporphyrin, and it is a precursor of heme, and normally it occurs at a very low concentration in RBCs. Therefore, an elevation of such might indicate early impairment of iron nutritional status. So when there is not enough iron available, as in iron deficiency, the protoporphyrin combines with zinc instead of iron. So therefore, forming the zinc protoporphyrin. So it serves no useful purpose in red blood cells since it cannot bind to oxygen. So erythrocyte protoporphyrin accumulates in red blood cells when there is insufficient iron present for proper heme synthesis. A small percentage of erythrocyte protoporphyrin may be unbound and can be measured as FEP, or if it is bound to a zinc ion, which is the 90% of the erythrocyte protoporphyrin, therefore it is measured as ZPP. So zinc is actually acts as a catalyst in iron metabolism in the activity of alpha aminolevulinic acid dehydratase enzyme, which plays a role in heme synthesis. It is also found in the structure of the growth factor independent 1B zinc finger protein, which functions as a regulator in erythroid cell growth by modulating gene expression specific to erythroid series. It has been proven that iron deficiency goes hand in hand with zinc deficiency as a result of studies measuring a significant decrease in levels of zinc in patients with iron deficiency anemia. However, more studies are needed to establish the benefit of zinc supplementation when treating iron deficiency anemia. So that's all po. Thank you.
Sir Jem,
Yes, ma'am.
can you reiterate the shift? Is it left shift or right shift for IDA?
It is right shift po, ma'am. Because when there is this here, there is an increased temperature between the increased temperature would affect the bonding between the iron and the oxygen. Therefore, it favors the tense state and resulting to more oxygen delivery in the tissues. So, in the context of iron deficiency anemia, the shift would be to the right po.
Okay, can you quickly scan the slides? I just have a question which I need to. Okay, so about the blood indices,
Yes, ma'am.
which of the blood indices will tell us or provide clue that the patient has a probable IDA?
Uh, I think, ma'am, they could all contribute to the diagnosis or identification of iron deficiency anemia, but I think it's more of the MCH or the mean cell hemoglobin because it actually is a measure of the actual or the average actual weight of hemoglobin in the RBCs po.
Any comment from the audience? You see, the blood indices actually they form part of the screening test, not just for IDA but in other many other disorders. Okay, so in a patient with IDA, what would be, for example, a patient with stage 3 IDA, what would be the expected results of the indices? Anyone can comment.
Ma'am Joy,
Yes.
good morning po.
Mm.
In regards, ma'am, to IDA anemia or iron deficiency anemia, as mentioned by Sir Jem, in iron deficiency anemia, you have a microcytic hypochromic cell. So the one that would be most likely affected in your indices would be your mean cell volume as well as your mean cell hemoglobin concentration. They would have lower values, less than 80 femtoliters for your MCV and less than 33 for your MCHC.
Okay, so that is correct. Okay, so when you look at the blood indices, okay, and you are ruling in or considering IDA, so the MCV, okay, and the MCHC primarily are the parameters that are most affected, okay, especially in the late stages of IDA. Okay, so now in stage 1 or even in stage 2, these blood indices would still appear as normal. But in stage 3, you will see a significant lowering of the values of these two blood indices. Okay, so such that you will need to do some more diagnostic tests like the iron studies that were mentioned earlier in order to establish that truly the cause of microcytosis and hypochromic anemia is a result of iron deficiency. Okay. Now, Sir Jem,
Yes, ma'am.
were you able to show a picture of the hemoglobin, the heme synthesis rather,
Um,
showing the iron molecule in that particular uh,
no po, ma'am.
illustration?
I think that that wasn't brought up last week po ata, ma'am. The
Yeah,
regard,
we forgot about it. But
yes.
while Miss Gabby is presenting the answers to the questions raised from last week, can you look it up?
Okay, ma'am. Okay po.
Okay, okay. Do you have any more comments? Okay, so the zinc, the role of the zinc in iron deficiency was also discussed. Okay, so is it more of a competitive binding, Sir Jem?
Ay, pardon ma'am, sorry.
For the zinc, can you say that it is a competitive binding with iron in
Yes,
iron
ma'am.
deficiency anemia?
Actually, I'm quite confused with that as well because I've read literatures that says it's competitive. However, most of the literatures I've read says that if only there is no iron present, then that would be the time that the zinc would bind to the erythrocyte protoporphyrin. But there are also literatures that says that there is competitive. Oh, I think the competition is on the absorption po, not the binding actually, but the iron and the zinc absorption in the enterocytes po. But on the binding, I think there is no competition between the iron and the zinc po.
So no competitive binding but rather compensatory. Since
Yes,
there is no iron available, the
yes, that's
body
quite
will find some way to
yes,
compensate by using the zinc.
yes, ma'am.
So in effect, in IDA, the zinc will it increase or decrease?
It will also decrease, ma'am, but the zinc uh, protoporphyrin, the because there is an association with the decrease of zinc within the presence of iron deficiency anemia. Therefore, the two will decrease. However, the zinc protoporphyrin will bind to the electroprotoporphyrin because there is no iron present to bind with the erythrocyte protoporphyrin. So, but in the due to this, there would be an increase in the free erythrocyte protoporphyrin and the zinc protoporphyrin po.
So increase in zinc protoporphyrin.
Yes, ma'am, but decrease
Okay.
in zinc levels in totality po.
Okay. So I hope we are all clear with the explanations provided by Sir Jem. Do you have any more clarifications? So well done, Sir Jem. Okay, so we will just wait for one more illustration for the heme synthesis showing the iron. Okay, so okay, last
You,
question: is iron recyclable? Can you?
yes, ma'am.
Okay,
Actually, the majority of the iron supply in our body is recycled by the macrophages from the senescent RBCs po.
so if you have IDA, so there is not much to recycle. Okay,
Yes, ma'am.
so that clinically the patient will manifest the symptoms. Okay, so of anemia.
Yes po.
Okay, so okay, thank you for the presentation, Sir Jem. Can we proceed with Ma'am Gabby?
Ay, thank you,
Okay,
ma'am.
thank you.
Morning po.
Morning.
Ah, morning po. Kung nakikita naman po, no?
Wala pa, ma'am.
Ay, wait lang. Okay, sorry. Okay na po, ma'am. Good morning po. Good morning, everyone. So today I will present the additional info about aplastic anemia. So first po is the age of incidence. Aplastic anemia can affect anyone at any age, but seems to occur most often in children and people over 60 years old. In acquired cases, mostly affects young adults ranging 20 to 25 years old and individuals over the age of 55 to 60 years old po. So the significance of CD34, CD20, and CD3 in aplastic anemia. So first po, CD34 is a surface antigen expressed by hematopoietic stem cells and early progenitor cells, while CD20 is used as a B cell surface marker. So it is usually positive in B cell malignancies. CD3 is a protein and a T cell co-receptor involved in activating cytotoxic and T helper cells. So this test po is a marker for malignant lymphoma and T cell neoplasms. So in aplastic anemia, CD34 is markedly decreased because the bone marrow is damaged. It cannot produce, since the bone marrow is damaged, there is no hematopoietic stem cells po. So CD34 is markedly decreased. But in some cases of aplastic anemia, like thymoma-induced cases, CD20 and CD3 can be positive po. So here is a figure again of a bone marrow in a aplastic anemia case po. The lower box po here is a IHC stain of a CD34 aplastic anemia case. So the brown cells are the CD34 positive cells. So as you can see, it is depleted po in a aplastic anemia case. Next po is ME ratio. So ME ratio is a ratio of myeloid to erythroid precursor in bone marrow. Normally, it varies from 2:1 to 4:1. So an increased ratio is caused by infections, chronic myelogenous leukemia, or erythroid hypoplasia. Decreased ratio may mean a depression of leukopoiesis or normoblastic hyperplasia. So in aplastic anemia case, ME ratio is decreased. So the table shown is a differential count po of a bone marrow po. Source po is Henry's po. Okay po.
Can you elaborate?
The child, wait lang. As you can see, ma'am, as the age of a person po increases, the ME ratio also decrease po. So in birth po, the ME ratio is 4.2, and then in adult po, the normal ME ratio of a bone marrow is 2.5 po. Next po. So in acquired aplastic anemia, there are two. Last week I shown two mechanisms po of acquired aplastic anemia. So the first po is the chemical associated aplastic anemia. So those factors po are dose dependent. So in radiation, it affects the cells. Uh, it affects the cells regeneration po. So in benzene is strongly linked to aplastic anemia before, but now it is considered less of a problem due to the reduction of exposure. So benzene and chloramphenicol are reversible po. Also, radiation-associated aplastic anemia po are reversible cases. So in radiation, single dose po of radiation cannot cannot affect the bone marrow. So the bone marrow is resistant to the radiation, unlike when the bone marrow is chronic has a chronic exposure to radiation. It can increase the risk factor of a patient to have aplastic anemia. So next po is associated immunologic diseases. These are the seronegative hepatitis, eosinophilic fasciitis, and thymoma. So there are two mechanisms of immunologic diseases associated with immunologic diseases po. The first mechanism is it it activates cytotoxic T cells which produce cytokines. So cytokines are pro-inflammatory po, especially the interferon gamma, which leads to the destruction of hematopoietic stem cells. So the other mechanism po, it is induced apoptosis through Fas and the Fas ligand on CD34 cells. So Fas cell surface death receptor po, the binding of this on its receptor promotes apoptosis. So the Fas ligand and the Fas po are receptors po associated in associated in apop apoptotic pathway po. Next po is telomere and dyskeratosis congenita. So telomere is the end of a chromosome presented here in the figure po. So each time a cell divides or as time goes by, telomeres become shorter, which leads to a healthy cell to its cell death po. So in abnormal cases like cancer po, telomeres are mutated, which causes the cell to be malignant po, to be immortal. So that causes the cancer case po of So in this keratosis congenita, it is characterized by mucocutaneous abnormalities, bone marrow failure, and pancytopenia. It involves triad of abnormal skin pigmentation, dystrophic nails, and oral leukoplakia, prematurely gray hair or hair loss. So it can be inherited in three different patterns, either in autosomal recessive, autosomal dominant, and X-linked recessive po. So in XLR, in X-linked recessive, there is a mutation on the long arm of the X chromosome, on the DKC1 gene. So DKC1 gene is is a is associated to the telomere po. AD autosomal dominant mutation in genes in TERC and TERT po. Same as with the DKC1 gene po. It is involved in telomere po. So these are telomerase enzyme. TINF2, which regulates telomere length. So in addition po to the telomere length, usually the normal telomere length po is 3 to 18 kilobase po. And in autosomal recessive cases po, mutation in genes TERT NHP20, NOP10, RAP53, and CTC1 po. These genes po are responsible for the telomere maintenance. No? That is all po.
Can you go back to the last slide?
Sige po. Here po, ma'am.
Okay, so based on this slide, you have three inheritance patterns, right?
Yes po.
So you have the X-linked. This one is recessive. Is it recessive?
Yes po. Yes
And
po.
then you have autosomal, one dominant and one recessive. So this is a good piece of information, okay, for this particular disorder, okay, because of the specific
Ay,
defect described. Okay, so if you look at the description, okay, so for the X-linked, you have the gene, the dyskeratosis congenita, one gene that is affected, okay, and due to the uh, long arm X chromosome, okay, defect. And then for the dominant, okay, so it's the enzyme that is affected. And then the last one, autosomal recessive, you have the genes that
genes po.
maintain the telomere. Okay.
Yes po.
So previous slide, the other one, ma'am.
Ay, nawala po. Sorry.
Mm,
Ito po, ma'am.
yung immunologic diseases, asan na yun?
Okay po.
So immunologic diseases, so associated with immunologic diseases, so you have the acquired type of aplastic anemia, and then you gave some examples. So you have seronegative hepatitis, eosinophilic fasciitis, and thymoma. So if you look at the description, okay, so you have two descriptions for these immunologic diseases. So they involve activation of cytotoxic T cells.
Toxicities. Yes po.
Okay, and then you have the other one, which is increased apoptotic activity. Okay, can you clarify with the class whether these three immunologic diseases that you just mentioned are autoimmune diseases? Because if you look at the description, so you have the destruction of the HSC in the first description. So something triggered your T cells, your cytotoxic T cells, so that they produce cytokines that
Yes.
destroy the HSC. And then the other one is an increase in apoptotic activity. Can you elucidate these three immunologic diseases? So
Ah,
why is it that they have increased cytokine activity, and then you have the ligand FAS, okay, that are present on the CD34 positive cell.
uh, ma'am, sorry. Actually, ma'am, I am not quite familiar with seronegative hepatitis po. But in thymoma, ma'am, it is a cancer of the thymus po. So there is an increase. There is an increase. I'm not quite sure, ma'am. Sorry if the abnormality, since it is cancer po, there would be a abnormal reproduction of the T cells po. So thus it causes the trigger po of the immune system po.
Okay. Ma'am Gabi, you just look up,
Yes po, okay po ma'am.
okay, so that we can be further clarified on why aplastic anemia becomes apparent with these three different immunologic diseases. Okay, so we need to find the connection. Okay,
Okay po.
although you've already provided some information about the destruction of the HSC. Okay, and then
Apa.
if the HSC is destroyed, of course you will have decreased CD4 positivity, right?
Yes po.
Okay, so we are finding the link with regard to the activated cytotoxic T cells and the cytokine signaling, particularly the INF gamma. Okay, so you mentioned about interferon gamma here, and then also some more information. Um, so in the apoptosis, okay, of a CD34 positive cell, okay, so you mentioned earlier that CD34 is a surface antigen, right?
Yes po.
Present on which cell again?
In hematopoietic stem cells po, ma'am.
Okay, so you have the CD34 HSC, CD34 positive HSC cell. Okay, so you have the ligand, which is FAS. Okay, so can you please clarify, okay, on the FAS? So FAS actually it's an acronym. Okay, so there is a meaning of the acronym FAS. So it would be more informative if you could
Ah,
provide some more details.
okay po.
Okay?
Yes
Okay.
po.
Okay. So for now, can we proceed with the next presentation or would you want a 5 minute short break? May we know who is the next presenter? Who is the next presenter? Okay, so you is volunteering. Okay, so before you present, we will have a 5 minute break. Okay. Yes, sir, Jam. Later after 5 minutes. So 9:22. Sir Jem, you may proceed.
Okay, ma'am. Thank you po. So, good afternoon. Good morning, classmates. So, this is the a picture or a flow chart that um, visualizes the uh, synthesis of heme. So the synthesis of heme starts inside the mitochondria. Succinyl-CoA and glycine, which are products of Krebs cycle, are combined by the alanine synthase to form aminolevulinic acid. So this aminolevulinic acid will go outside the mitochondria into the cytosol. So it would be acted upon by it would be dehydrated by the ALA dehydrase to form the porphobilinogen. So porphobilinogen uh, is the acted by a porphobilinogen deaminase to catalyze and form a linear tetrapyrrole. And this tetrapyrrole will be cyclized to form the uroporphyrinogen 3. So this uroporphyrinogen 3 is what we call as the precursor of hemes, chlorophylls, and vitamin B12. So the uroporphyrinogen 3 would be acted upon by the uroporphyrinogen decarboxylase, removing a carbon dioxide molecule to form the coproporphyrinogen 3. So this coproporphyrinogen 3 uh, is acted upon by a coproporphyrinogen oxidase to convert it into protoporphyrinogen 9. So this protoporphyrinogen 9 will go back inside the mitochondria where it would be acted upon by a protoporphyrinogen oxidase to form the protoporphyrin 9. So this protoporphyrin 9 will be acted upon by the ferrochalatase or it is also called as the heme synthase where this is also the step where ion is added. So after the addition of iron, the formation of heme, the heme will be formed po, to form the heme. Yes po. So that's the heme formation pathway po. If you could recall, I said earlier about the zinc, how it catalyzes the reaction of the formation of the aminolevulinic acid. So in this pathway, it further uh, signifies that zinc really is a you could really help in the synthesis of heme, therefore affects the iron in our body. Thank you po. That's all.
Sir Jem, you mentioned about the mitochondrion and cytosol. Can you quickly tell us the cell involved and the organ involved in these processes?
And, pardon, ma'am. Sorry.
What cells and what organ?
The heme synthesis is usually in the liver hepatocytes po.
Okay, so since it is the hepatocyte, okay, and the liver, that is involved in this procedure process, can you say that if there is liver disease, can it affect heme
Uh,
synthesis?
yes, ma'am. I think it have a correlation on the underlying condition that I mentioned or I discussed last week regarding the liver adenomas on how they affect hepcidin. Therefore, a condition or a disorder in the liver would affect the heme synthesis. In the context of heme synthesis, it would affect the production of heme if the hepatocytes are destroyed or if they have dysfunction in their there is dysfunction in the liver cells po. So I think if there is a condition where the liver is affected, therefore it would also affect the synthesis or the formation of heme.
Okay. Thank you, Sir Jem, for sharing this flow chart. Okay, so to
Yes, ma'am.
all the presenters, kindly make sure that you share the materials presented with the rest of the class. Okay,
Okay po, ma'am. Thank you po.
including the Q&A.
Yes, ma'am. Will do po.
Okay.
Thank
Okay.
you very much po.
All right. So can we proceed with the next presentation, please?
Yeah, may I do that right now? Hello, can you hear me? Hello?
We can hear you, but you are echoing. I think you need to turn off the other device that you have. Turn off the audio for the other device. So there will be no echo. All right.
Hello?
That's better. All right. You can proceed.
Hello, Professor, can you hear me?
Yes, loud and clear.
Right. Started? Hello?
Yeah. So we are waiting for your screen share.
Sorry? May I get started? Can you see my screen now?
Not yet.
What about now? Can you see my slides?
Yes.
All right, I'll get started. So, good morning, everyone. I am Zeno, and today my presentation centers on the topic of infectious mononucleosis. So, to begin with, let's take a look at a representative case. One fall night, a 5-year-old boy came into the emergency room. When asked what was wrong with him. His mother said he had been suffering from a fever for 3 days, as well as a sore throat, and his neck had been swelling for 2 days. As we can see in the pictures, there were swollen lymph nodes in his neck. He was suffering from eyelid edema. His tonsils are congested and swollen, and there are rashes on the mucous membrane. So, based on the above mentioned symptoms, what might be the most probable diagnosis? Is it eyelid tonsillosis? Is it nephritis? Or is it infectious mononucleosis? Well, before the announcement of the answer, I would like to walk you guys through several prominent features of infectious mononucleosis. So firstly, it is an acute disease caused by a primary infection with EB virus. And secondly, fever, angina, and lymphadenopathy are commonplace. And thirdly, it may elongate livers polemically. And fourthly, it may increase peripheral lymphocytes and abnormal lymphocytes. And fifthly, it is self-limiting. And finally, it generally has good prognosis. Well, then let's talk about the etiology of EB virus. So in 1964, Epstein and Barr first discovered a new human herpes virus from lymphoma cell lines cultured in vitro from the tissue of malignant Burkitt's lymphoma in African children, and confirmed as the pathogen of this disease in 1968. So it mainly involves B cells. The complete virus particles are composed of nucleoid shell particles, and envelope. Under electron microscope, it was spherical. It's about 150 to 180 nanometers in diameter, and the virus nucleic acid was 170 kb double-stranded DNA. And EB virus has very specific growth requirements, which is actually pretty strict. And it only grows in cultures of African lymphoma cells, blood from infectious, mononucleosis patients, leukemia cells, and brain cells from healthy people. So virus isolation is actually pretty difficult. EB virus has 5 antigenic components, each of which produces corresponding antibodies. Viral capsid antigen, which is abbreviated as VCA, can produce IgM and IgG antibodies. VCA IgM antibodies appear nearly and disappear after, it appears early and disappear after 1 to 2 months, which is a sign of early infected EB virus. VCA IgG appears a little later and can persist for many years or lifetime, or even lifetime. So it is not possible to distinguish new infection from previous infection. Early antigen, which is abbreviated as EA. So EA is an antigen formed at the early stage of EB virus proliferative cycle, and EAD component has the mark of active proliferation of EB virus. EA-IgG antibody peaks at 3 to 4 weeks after disease and lasts for about 3 to 6 months. Nuclear antigen. EBNA-IgG appeared 3 to 4 weeks after disease and normally lasted for life and was a marker of previous infection. Lymphocyte determinant membrane antigen. The B cell with LYDMA was the target cell of cytotoxic T cells its antibody was complement binding antibody with the same emergence and duration as EBNA IgG. It's also a sign of past infection. Membrane antigen, which is abbreviated as MA, neutralizing antigen, and it can generate corresponding neutralizing antibody, and its appearance and duration are the same as that of EBNA IgG. The source of infection mainly originate from patients and EB virus carriers, and the storage host is normally people. And its transmission route, so it spreads mainly by close oral contact, namely oral-to-oral transmission. And droplet transmission is not important. Occasionally, it can be transmitted through blood transfusion. And then we'll talk about the susceptible groups. So it is commonly seen in children and adolescents. Peak incidence in Western developed countries would be mainly targeted at adolescents, and in China it would be preschool and school-age children. The incubation period is 9 to 11 days for children and usually 4 to 7 weeks for adults. The typical manifestations of the onset are the fever body temperature ranged from 38.5 Celsius to 40 Celsius degree, and there was no fixed heat type. Some patients were accompanied by chills. The heat course is different, lasting for several days to several weeks even. They are as long as 2 to 4 months. A gradual or sudden retreat of heat, more accompanied by sweating, and early stage of the disease may have a relatively slow pause. The incubation period is 9 to 11 days for children and usually 4 to 7 weeks for adults. The typical manifestations of the onset are lymph node enlargement is commonly involved in superficial lymph nodes, most commonly in cervical lymph nodes, followed by axillary and inguinal lymph nodes. Mediastinal and mesenteric lymph nodes occasionally involved. It often subsides after a few weeks of heat retreat. The incubation period is 9 to 11 days for children and usually 4 to 7 weeks for adults. And the typical manifestations of the onset are pharyngitis, pharyngeal pain, and inflammation of pharyngitis, pharyngeal, tonsil, uvula congestion, and swelling, as we can see in the pictures at the right side. And a few tonsils have ulcers covered with thick cream secretions. Fusion or disappearance in 24 to 36 hours, generally do not invade and the pharyngeal mucosa. Hyperemia and edema of pharynx and nasal mucosa. Severe pharynx edema can cause dysphagia and airway obstruction. The incubation period is 9 to 11 days for children and usually 4 to 7 weeks for adults, as we have mentioned before. So the typical manifestations of the onset are hepatomegaly is usually less than 2 centimeters below the costal. ALT elevation was up to 2/3, and some patients had jaundice. Half of the patients had mild splenomegaly, pain and tenderness. Splenic rupture may occur occasionally. The typical manifestations of the onset are the rash was polymorphic, including macular pupilla, scarlet fever-like rash, erythema nodosum, urticaria, and sometimes hemorrhagic. See more in the truncaria, often appear in 1 to 2 weeks after onset. 3 to 7 days it subsides without pigmentation and desquamation. Other patients may develop neurological symptoms. The manifestations are acute aseptic meningitis, meningoencephalitis, brainstem encephalitis, peripheral neuritis, etc., and etc. And corresponding clinical symptoms may occur. Occasionally, pericarditis, myocarditis, nephritis, or pneumonia. And there are mainly 4 complications of infectious mononucleosis, namely number 1, hemolytic streptococcus infection of pharyngeal isthmus, and number 2, acute nephritis, and number 3, splenic rupture, and number 4, myocarditis. The total number of white blood cells can be normal and low in the early stage, and then it gradually increases, and the number of abnormal lymphocytes increases. The number of abnormal lymphocytes exceeds 10%, or the absolute number exceeds 109 per liter, which is of diagnostic value. Bone marrow findings. Usually no characteristic changes. There's usually no characteristic changes. So bone marrow hyperplasia is active. Lymphocyte proliferation may occur with a certain amount of atypical lymphocytic cells, but not as evident as in the hematology. There were no obvious changes in grain, red, and megakaryocytes. EB virus antibody detection. Anisotropic agglutination test IgM heterophilic antibody appeared in the first and second weeks of the disease and lasted for about 6 months. The detection titer higher than 164 was of diagnostic significance, and it was more significant if the weekly detection titer increased more than 4 times. Virus nucleic acid test. Clinical manifestation specific blood EB virus antibody, EB virus nucleic acid detection. Anisotropic agglutination test is also one of the diagnostic methods. And there is a local epidemic. The epidemiological data have important reference value. Mononucleosis is not necessarily caused by EB virus. Acute lymphoblastic leukemia, acute infectious lymphocytosis. The prognosis of this disease is generally good. The course of the disease is usually 1 to 2 weeks, but there may be a recurrence. Congenital immune deficiency patients infected with the disease rapidly deteriorate and eventually die. The disease is mostly self-limited, as I have mentioned above. It's self-limiting, and the prognosis is good, mainly for antiviral treatment and the symptomatic treatment. Against acyclovir, interferon, etc. Antibiotics are used only when streptococcal infections occur secondary to the pharynx or tonsil. In severe patients, a short course of adrenocorticosteroids can significantly reduce the symptoms. Children with severe illness can be combined with antiviral agents and human immunoglobulin. Sadly, there is no effective preventive measure for this disease. And acute period should be respiratory isolation, and its corrections should be used bleaching powder, chloramine, or boiling disinfection. And that's basically all about my presentation, and thank you for listening.
All right, so thank you. How do I pronounce your name again?
My name is Zeno.
Zeno.
That's
All right.
right.
So I jotted down some highlights of your presentation. Okay, so you mentioned about the 5 different antigens, right? So all of these 5 antigens are expressed during the infection.
Not necessarily. I guess it actually depends on the real circumstances. Not all the 5 antigens are expressed simultaneously.
Okay, so probably next week can you come up with a tabulation showing you just organize the 5 antigens and then you show um, the occurrences of these 5 different antigens. Okay, I hope you got my question. Okay,
Yeah.
so
So
basically,
in our next meeting, I am supposed to further expound the ins and outs of those 5 antigens, right?
right. Okay, so another would be for the Epstein-Barr virus. All right, so when it comes to viral infections, usually the virus has a preference to a cell. Okay, so we call it cellular tropism. So that is the term that applies when it comes to a virus having preference to a cell to which it will infect. Okay, now for the Epstein-Barr virus, can you tell us what specific cell or cells does it infect?
I think I haven't done much research about that.
You can include it in next week. You can include it.
Definitely. I will further explain this in our next meeting. So, would you please to repeat that again? It's I did not recall. It's called. Is it called cellular what?
Tropism. So I will type the spelling. Okay.
Yeah. Thank you. So, because I haven't really heard that word before. Sorry. Oh, it's cell tropism, right? Okay. Oh, I think I basically get it. So a tropism is a biological phenomenon indicating growth or turning movement of a biological organism, right?
Yeah, so you can just present next week to further elaborate on it. Okay.
Mm-hmm. Yeah.
Right. So
To further explain this phenomenon, right?
next would be can you show us next week a picture or a diagram about the recognition of the virus as it enters the oral mucosa. So in the transmission, so you mentioned that the transmission is oral to oral, right?
Yes.
So there must be something in the oral mucosa that is highly
Mm-hmm.
favorable for the virus to gain access or entry. Okay, so we are interested in knowing the site uh, that is being recognized in the oral mucosa so that the
Yeah.
virus will attach. Okay?
Yeah. Okay. So I'll try to find some charts or diagrams that clearly that clearly shows this process.
Yes, yes.
Okay.
So
Yeah.
the being oral to oral transmission, of course, definitely there is a specific site being recognized by the cell, okay, and then it receives the antigenic portion in the antigen receptor site. Okay, so that
Mhm.
is what we are interested in seeing, okay, by next week. Okay, so based on so the other comments, okay, so based on the signs and symptoms so that you presented, most of them are generalized. Okay, so you have urticaria, you have rashes, you have fever, and then many organs actually are affected based on the signs and symptoms. Okay, but good thing it is a self-limiting disease, right?
Yeah. It's
And
self-limiting.
also, yeah, very similar with streptococcal sore throat. So you have the four signs and symptoms that you shared earlier. So you have the hemolytic strep sore throat, you have the nephritis. Okay,
That's right.
so next week, can you show to us or share with us a blood picture of an Epstein-Barr virus infected patient? So if there are any abnormalities in the white blood cells seen or in the blood picture, blood examination, can you share with us next week a picture?
Yeah. Okay.
Okay.
Yeah. So it's a picture. It's a picture about the EB virus infected a patient infected by the EB virus, right?
Yeah.
And
Yeah.
yeah, and about the okay, yeah, and the symptoms. Well, what symptoms
Um, well,
show?
actually, just the peripheral blood smear examination,
Mhm.
the
Mhm.
blood smear picture.
Okay, all right.
And finally, the the next illustration that we are also interested is the cytokine signaling. Let me spell it
Mhm.
out in the chat box.
Okay, that's considerate of you. Cytokine signaling illustration.
Yes. So it's because based on the presentation, the information, there are there is activation happening when it comes to the lymphocytes, right? So there should be some series of events taking place among the cellular elements of the blood. Okay, so
Mhm.
this would include the action of cytokines that provide signals. Okay,
Mhm.
so I hope you
Yeah.
got it right, Zeno.
Yeah. Yeah. Basically, I got it.
Thank you. Do you have any
Yeah.
more questions from the audience? Please feel free to comment and share and ask Zeno about his presentation. Was it explained why it is called mononucleosis?
Um, I don't think I have given a given a very clear explanation of why it is called infectious mononucleosis. Yeah, I guess I can to give some further explanations of this in my next presentation.
All right. Okay, thanks.
Okay, yeah, thank you for your enlightening comments.
So, how about the audience? Any comment? All right. So, if there are no more questions, can we have one? Okay, Sir Kenneth, go ahead.
I'm just curious. What are the actions of? You mentioned that the treatment for infectious mononucleosis is interferon, ganiclovir, and acylclovir. I'm just curious. What are the actions of these drugs that would treat the infection? Also, is the what is the gold standard for EBV detection?
Um, y- you mean what is the gold standard for EBV detection?
Yeah, for
Right,
that.
like you mean like how are we supposed to like how do we detect EBV virus, right?
Yeah.
Okay. So I guess uh okay, this is probably my guess. We can use the heterophile antibody test. It's a mononucleosis spot test is it's actually a blood test used to determine whether you have contracted the EB virus, the virus that causes this, and the doctor may order this test if you have the pertinent symptoms. Um, I'll I'll type this in our chat window.
Can it be replaced by the nucleic acid detection? So, you mentioned that nowadays you can use the nucleic acid detection.
Mm-hmm.
Can it replace the heterophile antibody titer test, or it remains as still the gold standard?
Well, I don't think they are mutually exclusive. I think they're more like complementary to each other.
It's more of a supplemental test, right?
Yeah, yeah.
Any other comment? Do we still have another assigned presenter for today? I think we're supposed to have at least two presenters for every meeting. All right, so if there are none, I would like to give some reading assignment for the class. Okay, so please take this down. Okay, so please review the following. So number one is the principles of hematology instrumentation. Okay, so there are many changes already when it comes to instrumentation in hematology. So please review the principles behind these instruments or machines. And number two, also please review the significance. So analysis and interpretation of scattergram and schistogram. So let me spell that out. Were you able to read the my message in the chat box? Okay. So just a review of, I know you already have background, you already have some information about the principles of instrumentation. Okay, so being used for a wide range of hematology analyzers. Okay, and then the other one would be interpreting, okay, analyzing and interpreting a scattergram and a histogram. Okay, so these are the visual representations of the distribution of cell populations, okay, generated by your hematology analyzer. Okay, so you have the plot, the scattergram or the scatter plot or the histogram. Okay, so how to interpret these graphs or pictures. Okay, and then the other one would be, okay, so on April 2 there will be a practical exam, so I will show a picture of a particular cell, and then you will identify the cell, and then there will be some side questions. Okay, so I will now what kind of cells do you need to study? Of course you have to study the normal cells. Okay, so what is the normal appearance of an rbc, wbc? Okay, so the different types of wbc, not only when it comes to appearance, but of course the description of each of these cells. For example, for the red blood cell, what is the average diameter of a normal red blood cell? Can you still recall, sir and ma'am, the average diameter of RBC? RBC, Sir Peter. So between 6 to 8 microns or micrometers. Okay, so will range from 6 up to 8 micrometers in diameter. Okay, so the diameter actually pertains to the size of the RBC. Okay, so the description with central pallor, isn't it? Biconcave. Okay, so those are usual descriptions of normal RBC. And then, of course, for the white blood cell, for example, is are there differences in terms of cell size or diameter between neutrophil, lymphocyte, monocyte, etc. Okay, so these are very basic descriptions of normal cells. Now, another would be you need to refresh yourselves about the appearances of cytoplasmic inclusions, if you still recall, the different granules, okay, that can be seen depending on the disorder. Okay, so please review. So I strongly recommend that you check the, if you need a reference for the different pictures of the cells, you can go to the website of, either you can go to ASH or you can go to WHO. You can also try to check CDC. Okay. So those are, I typed them on the chat box. So those are very good websites providing reference materials for you to check and study. Okay. Any clarification with regards to the practical exam on April 2? There will be a separate practical exam for leukemias. Okay, so for hematologic malignancies, there will be a separate practical exam. Okay, so for April 2, it will be more on the normal blood cell morphology. and some of the cytoplasmic inclusions. Okay. But for leukemic cells, okay, it will be given as a separate exam. Do you have any question?
Ma'am Joy.
Yes, Sir Peter.
Mag-meet tayo next week, ma'am.
Yes, may
Midterm.
presentation.
Okay.
I don't know who's assigned for next week. Would you know who is assigned for next week? Definitely, somebody should be presenting next week.
So ma'am, to clarify lang po, there will be no midterm exam, ma'am. Tama po.
Wala. So that would be April 2 mag-practical exams tayo.
Okay, ma'am. Thank you po.
Okay, so
Si Ma'am
who?
Jeff daw.
Ma'am Jem, ikaw mag-assign? Ay, ikaw mag-present? You will present next week? Besides Ma'am Jem, who else?
Me po, ma'am. Kenneth.
Okay, okay. How many items for the practical exam? It depends. Minimum of 20 questions, maximum of 30 questions. All right. So when you study the different cell morphology, okay, so you have to also study the characteristics, okay, so how the description of these cells, okay, and of course, part of that would be to review, okay, the lineage, okay, the progenitor cells responsible for giving rise to these mature cells, okay, so package na yon. So it will come as a package, okay, so when you study, you do not just memorize the appearance of the cell, but comes with some side questions like the origin, the progenitor, the lineage, perhaps even the reference values would be asked. After the quiz, there will be a short presentation. But definitely next week we will have the presentation of your classmates assigned for the day. All right. So are there any more clarifications? So if there are none, so the remaining of the class hour will be freely given to you. So I'm going to dismiss you now. So you can start studying the reading assignment. Okay, so someone is asking, Sir Pax, okay, can we still use Sturgeon Roebuck Stressinger? Definitely, definitely, Sir Pax. We are not limiting the references for you to use.